Good afternoon, everyone.
Good afternoon, sir.
So, today we are going for a new topic in the neurology section. It's very important, and you please go through your textbook because this is a very big topic, and it's not possible to teach everything or to discuss everything about epilepsy in 45 minutes to 1 hour. So, I'll just tell some important points here, but rest of the things you have to go through the main textbook. Now, to start with, what commonly asked in exam is what is seizure and epilepsy? Or are this terminology they are same or there is different? So definitely there is different. All seizures are not epileptic. So by definition, a seizure is a paroxysmal event due to abnormal, excessive, or synchronous neural activity of in the brain. So it's just a paroxysmal event, and this is basically due to excessive neuronal discharge. But what does it epilepsy means is when a person is having recurrent seizures and due to some underlying pathology. It may be sometimes metabolic, it sometimes may be some reversible conditions, it may be sometimes some irreversible conditions, but definitely there are some underlying pathology and for which there is some recurrent abnormal movements. And that's why a person with a single seizures or recurrent seizures due to correctable or available circumstances does not necessarily have epilepsy. Just giving a simple example, like a patient with hypoglycemic coma or patient with diabetic ketoacidosis, sometimes they may have 1 or 2 episodes of single seizures, but we do not label that patient is having epilepsy. So what I'm talking about that seizure and epilepsy, they are not synonyms. Like a patient may have seizures but may not have epilepsy. A seizure is simply a paroxysmal event due to some abnormal, excessive neuronal discharge. This is not normal, abnormal discharge. And epilepsy when a patient is having a recurrent attack of abnormal discharge. Sometimes some persons may have single seizures, like mostly we found it with some alcohol intoxication and sometimes with some metabolic disease, mostly with hypoglycemia or diabetic ketoacidosis, and even with sometimes patient with chronic kidney disease also, they may have 1 or 2 episodes of seizure. Suppose a patient with hypoglycemia is having 1 episode of just abnormal movement of the body, that does not signify that or that does not tell that patient is having seizures, and patient may not require anti-epileptic therapy. This is why this is important, because this is one of the things. Suppose if you label the patient as epilepsy, then you have started some medicines, and then normally that medicine has to continue for 2 to 3 years. And suppose if patient is not having epilepsy and you are labeling it as epilepsy, then unnecessary patient will take those toxic drugs for 2 to 3 years. On the other way, if you miss a patient, like patient is having just 1 episode of seizures, but due to some non-correctable measures, due to some underlying pathology, then patients may require anti-epileptic medicines. And if you don't prescribe anti-epileptic medicines, then patient may have some complications. So it's very important to differentiate between the seizure and epilepsy. I'll come to that later, because some of the in some conditions in the first seizures you have to start medicines, but normally in the normal day-to-day circumstances or in normal day-to-day OPDs, in a simple seizures or in just 1 episode of seizures, we do not treat. We'll just try to find out some reversible cause. If these days, like patient is hypoglycemia, you correct with sugar, then patient do not require anti-epileptic therapy. Prevalence of seizure is much higher than the epilepsy. Epilepsy prevalence is estimated as 5 to 10 persons per thousands, but the prevalence of seizures, it comes around 0.5 to 1% of the general population. So okay, so this part is clear. There is difference between the seizures and epilepsy. Classification of seizures is not a simple, it's a complex thing, and always there are some modifications of classifications. But in the simple way to learn about the classification of seizure is whether it is focal or generalized, and sometimes you may not like unknown onset. It may be focal, it may be generalized. But broadly, you can differentiate it is whether it is a focal onset seizure or it is a generalized seizures. Focal onset seizures, again, you can classify it whether it is they are having motor seizure, sometimes patient may have sensory seizures, sometimes patient may have autonomic seizures, sometimes patient may have cognitive or some other seizures. Generalized seizures broadly classified into two groups. One is absence seizures and one is tonic-clonic seizures. Others clonic, atonic are part of tonic-clonic. So basically absence and non-absence. Why it is again important? Because the treatment protocols are different. For absence seizures, we are having different groups of drugs. And for tonic-clonic or generalized tonic-clonic seizures, we are having different class of drugs. And sometimes difficult to exactly point it out to whether it is focal or generalized, then we can classify it as focal with generalized seizures. Patient may have combination of start with focal, then convert it to the generalized seizures. How to differentiate whether it is focal or generalized? That focal seizures normally originate from one cerebral hemispheres, and once you level it as focal seizures, that almost in the more than 90% signifies that this is due to some local pathology in the brain. So on the other way, if you level it as a focal seizures, then means indirectly that patient require anti-epileptic therapy. On the other hand, the generalized seizures arises within a rapidly engaged network distributed across both cerebral hemispheres. As I have told you, that focal seizures are usually associated with structural abnormality of the brain. In contrast, generalized seizures results from cellular, biochemical, or structural abnormality that have a more widespread distributions. But there are always clear exceptions. Sometimes focal seizures may have metabolic cause, and sometimes generalized seizures may have focal cause. But normally, suppose if there is some abnormal movement of the right hand, normally we think of pathology in the left hemispheres. And if patient suppose having some generalized seizures and all, you try to rule out some metabolic cause like diabetes, alcohol, CKD, sometimes maybe hepatic encephalopathy, or sometimes maybe due to some drugs cause drug induced. So in GTCS or generalized tonic-clonic seizures is mostly of metabolic, and in focal seizures is mostly of organic. I'll show some videos to differentiate how to differentiate between focal and generalized seizures. So what is this? This is a typical of generalized seizure. Electronic, clonic, and then there will be post-ictal confusion. This is floating through the angle of mount. It's one of the features by which you can differentiate seizures versus true seizure versus false seizures. And see the movement of his eyes is floating to the angle of the mouth. And this one is generalized GTCS. It's called generalized seizures. Next, you have to find out whether there is any organic pathology or it's sometimes due to some metabolic cause. Go to the next slide. Here you observe these things. Have you seen the angle of the mouth, some movement? The twitching movement, this is the focal seizures. Next, and focal seizure is, you can, sometimes it may be with altered sensorium, sometimes without altered sensorium. Here, have you seen this one, the movement of her leg, right lower limb? This is abnormal movement of the right lower limb. So this is focal seizures. Again, both these two without any loss of consciousness. So it's called simple motor seizure or simple, you can elaborate as simple partial seizure or simple motor seizures. So these are some pictures of true seizures, and one is true GTCS and others are focal seizures. Coming to causes of seizures, you can differentiate by different age group and sometimes by different etiologies like infective causes, metabolic causes, inherited causes, drug-induced, and sometimes these are same only. You can differentiate as per age group or as per causes. In the neonate, that is less than 1 month, and the most common cause of seizure is perinatal hypoxia or ischemia, and sometimes intracranial hemorrhage or trauma, birth trauma. Sometimes, although not very common, but acute CNS infection like Listeria monocytogenes can cause encephalitis in neonate. Metabolic disturbance like hypoglycemia, hypocalcemia, hypomagnesemia, pyridoxine deficiencies, drug withdrawal, developmental disorders, and genetic disorders. In infant of more than 1 month to less than 12 years, the febrile seizure is most common, in between 3 months to 5 years. Again, genetic disorders, different form of epilepsy syndrome that are common in children. CNS infection, again, all those local infection like Japanese encephalitis, herpes simplex encephalitis, some other infections can cause seizures, developmental disorders, and trauma definitely will come in all age group. Then in adolescents, in between 12 to 18 years, trauma is the most common cause, followed by genetic disorder. Infection will come again. Brain tumor, they started from 10 years, then illicit drug use, and idiopathic. Sometimes it's very difficult to find out some causes, especially with those epilepsy syndromes. Young adults, that is 18 to 35 years, trauma again is the most common cause, followed by alcohol withdrawal, then illicit drug use, brain tumors, and all those epilepsy syndrome. In elderly or in older adults, mostly the CBA will come here. Mostly the embolic stroke, and they can cause seizures, brain tumors, alcohol withdrawal, metabolic disturbance definitely is one of the important cause, especially in elderly. And all form of metabolic encephalopathy started from renal failure to hepatic failure, electrolyte abnormalities like hyponatremia, then hypoglycemia, hyperglycemia, both hypoglycemia as well as hyperglycemia, other degenerative disease, and again some of the syndromic diagnosis, they are common in elderly population. So what we are getting mostly in case of neonates, mostly of hypoxic or ischemic injury. In case of infants, febrile seizures, infants less than 12 years. In between 12 to 18 years, mostly the trauma, infection, and genetic disorders. Young adults, again trauma, alcohol, and tumor. In elderly, CVA, metabolic, tumor, and alcohol withdrawal. Coming to epilepsy syndrome, they are not very common, but this is important because once you label it as a epilepsy syndrome, then most of them, they require medicine for lifelong. So what is epilepsy syndrome? It's a disorder in which epilepsy is a predominant features, and with sufficient evidence through clinical, EEG, radiologic, or genetic observations. One thing you have to remember, like that confirmation of epilepsy can be done from clinical, like I've shown you in the video. If you can see that patients having that seizures, either motor or sensory seizures, then you can label it as epilepsy without confirming with EEG or any imaging diagnosis. But sometimes suppose patient gives only history, then you have to confirm it through either electroencephalogram or through MRI or CT of the brain. Three most important epilepsy syndromes are juvenile myoclonic epilepsy, Lennox-Gastaut syndrome, and Mesial temporal lobe epilepsy syndrome. In case of juvenile myoclonic epilepsy, where it's mostly of generalized seizures, it's mostly of unknown etiology and mostly characterized by the bilateral myoclonic jerks. That is just jerky movements which may come as single or maybe sometimes repetitive. The myoclonic seizures are most frequent in the morning after awakening and can be provoked by sleep deprivations. This is important. Sometimes you have to confirm the diagnosis by stimulations. So what you can suppose there is some history, but no definite like patient gives history, but you have not seen the myoclonic just because they usually that like I have shown you in the lady, she's having some jerky movements over the legs. Sometimes patient may give some history of twitching movement of the eyes, sometimes twitching movements of some muscles. So it's maybe difficult to visualize. Then you can provoke. You can admit the patients and you can provoke with sleep deprivations, and there will be that will cause increased myoclonic jerks. In case of juvenile myoclonic epilepsy, consciousness usually preserved in all form of focal seizures and all myoclonic and all these are basically focal seizures. Normally, consciousness always preserved. Consciousness normally, patient usually has loss of consciousness only in case of generalized seizures. Focal seizures normally they preserve. Although there may be sometimes in case of severe seizure, severe focal seizure, severe myoclonus, there may be impairment of consciousness. Although complete remission is relatively uncommon, and the seizures respond well to appropriate anticonvulsive medications. So here again you have to remember is that you have to continue the anti-epileptic therapy for lifelong, and all those myoclonic syndromic diagnosis always we get some sort of family history of epilepsy. So here definitely mostly we will get the myoclonic jerks with normally preserved consciousness, which can be provoked by sleep deprivations, mostly occurs early in the morning, and for confirmation sometimes you have to ask for EEG, but that again may be normal, and normally they do respond with normal anti-epileptic drugs, but sometimes what you have to remember is that these medicines have to continue for lifelong. Otherwise, if you stop in between, there is a chance of recurrence of this epilepsy. Lennox-Gastaut syndrome is not very common, it's less common than the juvenile myoclonic epilepsy. It's characterized by triad of multiple seizures type, usually GTCS, atonic or atypical absence. In JME, juvenile myoclonic epilepsy, mostly the myoclonic. Here it's mostly of GTCS, and always we get some EEG abnormality, and here normally we get impaired cognitive functions. And normally this syndrome associated with some CNS malformations, maybe sometimes with hypoxic ischemic encephalopathy and bad trauma, sometimes following some infections. And usually they have poor prognosis if you compare with the juvenile myoclonic epilepsy, because they have some underlying CNS disease. In juvenile myoclonic epilepsy, they are usually with underlying CNS disease, but Lennox-Gastaut syndrome, they are mostly with some underlying CNS disease. That's why the prognosis is not very good. Again, this group of disease, you have to continue anti-epileptic therapy for lifelong, but unlike juvenile myoclonic epilepsy, they poorly response, and most of them they require antiepileptic 2-3 multiple antiepileptic therapies, and sometimes you may have to go for some surgical treatment. Mesial temporal lobe epilepsy syndrome, again it is one of the most common syndrome associated with focal seizures, and there are distinctive clinical, EEG and pathologic features. In the clinical, you will get history of febrile seizures, family history of epilepsy, early onset, and again they are intractable seizures. Intractable seizures means they do not respond with normal anti-epileptic drugs. And if you do the EEG, you will get the temporal spikes. In the EEG, normally we see the different lobes, like sometimes you get frontal spikes, sometimes you get temporal spikes, sometimes occipital spikes, parietal spikes. Here in case of by name, you can suggest that mesial temporal lobe epilepsy, you'll get some temporal spikes. And if you do the MRI, you'll get the small hippocampus here, and sometimes with small hippocampus with small atrophy of the temporal lobe. So if you do the MRI, if you get hippocampal atrophy, you get temporal lobe epilepsy, temporal lobe spikes in the ECG, and there are some family history of febrile seizures, then probably you are dealing with mesial temporal lobe epilepsy. Again, this is important to diagnose because this group of syndromic epilepsy, they again poorly respond to epileptic therapy, and now with some surgical treatment and sometimes with some neuro interventions, there are different modalities of treatment. This is one of the seizures. Normally it comes as a short note in the exam also. Febrile seizures, it's common in children, mostly between the 3 months to 5 years of age, and a majority occurs during the first day of fever. So it's normally with the infections. If patient is having sometimes very high infections like Japanese encephalitis, herpes simplex encephalitis, with the first day of spikes, they may have some simple seizures, mostly of simple and generalized seizures. And normally there are two types. One is very simple, one is complex. So simple one is basically single seizures, is generalized and is lasted less than 15 minutes. And complex one, they are of multiple seizure, recurrent seizures, mostly of focal, and they last for more than 15 minutes. And 1/3 of 25 to 30% of them, they used to have at least one recurrence. Otherwise, prognosis is very good. You don't have to treat this group of seizures, and less than 5% only they may develop epilepsy laterhood. And treatment, just you have to treat the primary source of infections. You have to give paracetamol for fever, and there is no, what you have to remember is there is no role of prophylactic anti-epileptic therapy here. Sometimes the patient is having recurrent seizures, you can give some sort of diazepam syrup in case of children mostly. So you can give diazepam syrup at a dose of 1 mg per kg in 3 divided doses. That also intermittently, and because you have to see the risk and benefit ratio, as there is a very less chance to develop epilepsies, most of them they do not require treatment. Just you have to treat fever. That is the only treatment, and you have to treat the source of infection, source of fever. So what you have to remember is febrile seizure. From febrile seizure is first definitely you have to rule out febrile seizures from other syndromic diagnosis, or sometimes patients having some underlying neuronal pathology, and patient is having Japanese encephalitis. Seizures may occur due to fever per se, or sometimes maybe due to Japanese encephalitis or cerebral malaria. Then why it is important? Because if it is due to infection per se rather than febrile seizures, then patients may require anti-epileptic therapy. And it is, if you label it as febrile seizures, that means patients do not require treatments. Against that point comes here is, suppose you are labeling it as a febrile seizures and patient is having actually true seizures, then patients may have some unnecessary complications because of recurrent seizures. And if you label it as some organic seizure and actually it was febrile seizures, then unnecessarily you are putting some anti-epileptic therapy to the patients. That medicine itself has many side effects. So it's very important to differentiate whether it is a simple febrile seizures or it's some seizures due to some other factors. Regarding anti-epileptic drugs, we are having first-line drug and we are having second-line drugs. What you have to remember is about the at least name of few first-line drugs and few second-line drugs. Phenytoin, carbamazepine, valproic acid. These three are the most commonly used first-line anti-epileptic drugs. Phenytoin we use at a dose of 100 mg TDS or 300 mg HS at the initial dose. Carbamazepine we give 200 mg twice daily, and valproic acid at a dose of 500 mg 2 or 3 times daily. Normally, valproic acid we prefer irrespective, especially if you are having doubt about the focal or generalized seizures. And in case of focal seizures, definitely valproic acids do better than the phenytoin and carbamazepine. Especially phenytoin has lots of side effects in elderly. It can cause some arrhythmias, postural hypotension, it can cause gum hypertrophy. Carbamazepine otherwise okay, it's well tolerated other than giddiness. Valproic acids, except hepatitis, it's normally well tolerated. Benzodiazepine we use for acute control, not for chronic. And barbiturate nowadays we hardly use, but still you can give phenobarbital sometimes. Amongst the newer therapy or second line therapy, drug of choice definitely levetiracetam. And we have experience with lamotrigine, topiramate, zonisamide, lacosamide, ethosuximide, gabapentin, and tiagabine. All of these drugs are not without side effect. Most of them they are having side effect in terms of drug interactions and in terms of weight gain, weight loss, and lots of other side effects, especially with the second line of drugs. And this one is for theoretical interest. The mechanism of action of all those anti-epileptic drugs, it's there in the textbook. It normally comes in the MCQ, so you have to go through it in the from the textbook. Mostly they are of sodium, they inhibit sodium dependent channelopathy. Basically, they inhibit some channels, like some of them they inhibit sodium channels, some of them they inhibit calcium channel, some of them they increase the GABA activity, sometimes with either receptors or availability of GABA, and some they modulate the synaptic vesicles. Diagnosis, what is more important is the history here. So it's purely based on clinical grounds, and most of the time other examinations or laboratory studies are upon normal. If you see, suppose patient comes to OPD, they still come with like history of seizures, and normally in on the other part of the day they remain normal. During the time of seizures only they used to have abnormal activity and postictal confusions. So history should focus on symptoms before, during, and after the episodes, and also should focus on the factors and predisposing events. The general physical examination includes the signs of infection and systemic illness, and signs of head trauma and use of alcohol or illicit drugs should be find out. Here, although theoretically it's easy to say to differentiate true seizures versus false or pseudo seizures, in practical situations, especially if young girl comes or young boy comes with history of seizures, sometimes it's very difficult to differentiate between the true seizures or false seizures. There are some points, I'll come to that later. So, laboratory studies, normally we investigate, like we have to ask for the routine blood, sometimes electrolyte. In emergency, you have to send glucose, calcium, magnesium, and you have to rule out chronic kidney disease, chronic liver disease. Sometimes you have to ask for some toxins in the blood. Lumbar punctures may be required if you are having strong suspicion for meningitis and encephalitis, and always you have to rule out HIV and other cellular like hepatitis B and C. EEG, how does EEG helps? Because normally in all peripheral centers, if you work in the peripheral centers, it's very difficult to get it done and difficult to interpret. Like unlike ECG, normally ECG, even all the MBBS students, they are a little bit of accustomed with how to read the ECG. What is the POF, QRS complex, TOF, STOF? At least you can differentiate between ST elevation MI or non-ST elevation MI. But here in electroencephalography, it's very difficult, almost like 20 pages, and always to differentiate between artifact and spikes. It's not easy if you're not trained in neurology. So how does electroencephalography it helps? It's sometimes diagnosis of epilepsy. If you are having some doubts, especially in seizure comes intermittently and young children, and if you are having something doubt about whether it is true seizure and pseudo seizures, then it helps in the diagnosis of epilepsy. And it helps in the classifying seizures, like whether it is focal seizures or generalized seizures, and definitely it helps in selection of how to select the anticonvulsive drugs. Like if you are having focal seizures, maybe you use different drugs. In case of generalized seizures, you can use the different groups of drugs. And sometimes with underlying pathology, it helps in the prognostication. Like in general, suppose person is having simple seizures or epilepsy and with normal EEG, that implies better prognosis. But whereas suppose person is having some seizures or some movement disorders and along with some abnormal spikes in the ECG, that suggests a poor outlook, or maybe that patient will require lifelong therapy, those who are having abnormal EEG. Imaging, again, all patients, we should not ask for imaging, especially in selected patients. Sometimes they may require imaging. The number one point is, especially in patient with new onset seizures, and especially if you are having facility, always get one imaging done to rule out any structural abnormality. But suppose if you are having clear idea in the clinics that a patient is having hypoglycemia, there is one seizures, and if you, after correction of hypoglycemia, there is no further or repeated seizures on admission, then you may not require exactly that CT or MRI. And especially in children, and sometimes some of the are very specific of absence epilepsy, where ideally MRI or CT brain will not help. Then you may exclude imagings. And if you compare with MRI and CT, definitely in seizure or in epilepsy, MRI is better than the CT. CT is always better to rule out hemorrhage. So that rule of thumb is in patient with seizures, especially with the new onset seizures, if you are having facility, then always ask for one imaging to rule out any structural lesions. If you are very clear about your etiology, like patient already on CKD and you are sure about the cause of seizures, sometimes you may omit, but still you better rule out some, because you never know, sometimes like patient with CKD may have hemorrhage also. So in practically all cases, you ask for imaging. Exception is definitely in case of children with like typical of febrile seizures. Then you don't require to go for imaging, and especially patient with epilepsy, absence epilepsy, you may not require imaging. Differential diagnosis: one is syncope, second one is psychogenic seizures, metabolic disturbance, migraine in children, breath holding spells, and two of the sleep disorders which sometimes may disturb in the diagnosis of seizure is one is night terror and second one is sleepwalking. Syncope versus seizure. This is important. How to differentiate seizure from the syncopal attack. One is, if you, these are not, none of these features are 100% specific for either of these. Always, whenever we diagnose a seizure or syncope, we take multiple factors into considerations. Like, patient is having immediate precipitating factors, like maybe emotional stress, pulse alva, orthostatic hypotension, and then some definite cardiac etiologies are there. Then you may have syncope in favor than the seizure. But again, seizures sometimes, especially with some of the seizures, may precipitate by emotional stress. Pre-monitoring symptoms. Mostly in some of the seizures, you may have some aura type symptoms. Different types of smell they used to get, like, and they can feel that I'm going to have a seizures. That is, that feelings is known as aura, and especially in GTCS, generalized tonic-clonic seizures, sometimes aura may precipitate the next group of that involuntary movements. In syncope, there will be like tiredness, feeling of nausea, sometimes vision difficulty before syncope. Postures at onset, differently that in seizures is variable, and usually in syncope, patient is standing and suddenly he feels giddy and suddenly falls down. Duration of unconscious is minutes in case of seizures. In case of syncope, just fraction of seconds. Again, sometimes it's difficult to differentiate from absent seizures, which can last for only for seconds. That movement, as you have seen in the tonic-clonic movement, especially GTCS, it lasts for almost a minute. But here in syncope, sometimes you may have some abnormal movement, but normally they do not last for more than 15 seconds. And post-ictal confusions is quite often in case of seizures, as you have seen with the first video. The patient went for this post-ictal confusions. In syncope, normally do not get post-ictal confusion, and tongue bite and incontinence, they normally do not occur in case of seizures, and sometimes they are common in case of seizures and they are rare in case of syncope. Next one is how to differentiate seizures versus pseudo-seizures. Again, all these points, that seizure points, normally do not get in case of pseudo-seizures. Pseudo-seizures, two of the important things, that tongue bite and incontinence will not get in case of pseudo-seizures. But again, sometimes patients may be very clever and they have nowadays days to read in the Google, and they will get that post-ictal confusions, you may get tongue bite, so they may bite their tongue by, if they know also that it can cause a little bit of harm, but that the tongue bite and incontinence may happen sometimes. So, but it's like hard point for true seizures. And one of the important point in case to differentiate seizure and versus pseudo seizure is you can provoke the pseudo seizures. Like if you ask the patients to do the same things in front of you, then patients may repeat the same things on verbal command. That is likely to be mainly, or you are dealing with pseudo seizures. One investigations you can ask for, like in case of true seizures, normally that serum prolactin level goes high after immediately if you take the samples and if you do the serum prolactin, it goes high, which should not go high in case of pseudo seizure. Treatment, number one is treatment of underlying cause, like if patient is having metabolic hypoglycemic, correct sugars, and antiepileptic that do not require SOL, removal of structural lesions, and in those with underlying conditions, sometimes you may have to give medicines for 1 to 2 years. And then avoidance of precipitating factors. In some of the situations, some of the seizures, they may provoke with some specific situations. It was exact mechanism is not known, but it has been shown that some of the situations may lower their seizure thresholds. That situation to be avoided, like sleep deprivations, as you have seen in case of juvenile myoclonic epilepsy. If you deprive the sleep, then there is increased chance of seizures. Same thing with alcohol. If patient takes alcohol, then there is a chance to have chance of seizures is more. And there are some atypical or very uncommon type of seizures which may be aggravated by some specific music, specific smell, specific like hot bath, cold bath. So there are some specific precipitating factors, and you have to ask the patient to avoid those precipitating factors. Antiepileptic drug therapy, here it is important when to initiate, because once you initiate antiepileptic drugs, then normally it's very difficult to stop, number one, because in most of the scenario you have to continue for long therapy. You may have to go for 2 years, 3 years, and suppose patient is well controlled with antiepileptic drugs, then it's like you have to go for gradual withdrawal. So when to initiate, there are some points when to initiate. So a patient with seizure, if there is some abnormal neurologic examinations, like suppose with seizures, patient is having plantar extensor, patient is having accelerated reflexes. One is with seizure, if you get some abnormal neurological examinations like plantar extensor, then ocular palsy, and then sometimes with exaggerated reflex, then definitely you have to start it. And if patient presented with status epilepticus, I'll come to that, what is status epilepticus, post-ictal paralysis, strong family history, and there is abnormal EEG or abnormal MRI or CT brain, then definitely you have to start anti-epileptic therapy. What anti-epileptic therapy you have to choose? One is in case of GTCS, normally we choose valproic acid. In case of focal, you can choose phenytoin and carbamazepine as a first choice. In case of absence, always you have to go for either valproic acid or ethosuximides. In case of myoclonic seizures, either valproic or lamotrigine or topiramate. These four are main type of seizures. So this one is very important to remember. If patient is having GTCS, always go for valproic acids. If patient is having focal, you go for either phenytoin or carbamazepine. In case of absence, again you go for valproate. In case of myoclonic or atonic, again you go for valproate. So valproate you can give even focal seizure also. So you can. That's why I've said that if you don't know about the cause or about the onset of seizures, always go for valproate. If you are sure about the focal seizure, you can go for either phenytoin or carbamazepine at the first choice. Second choice, you can go for levetiracetamine, which works normally against all the type of seizures. And then once you initiate, then always you have to monitor the therapy. Monitor, how will monitor that? Although it's written that monitoring of the serum antiepileptic drug level, until and unless you are dealing with, you are working in a special neuro setup, normally we do not do the serum level. What you should know about how to monitor the drug toxicity, like for phenytoin, normally we do ECG and like gamma hypertrophy and all those things, and for valproic acid you have to monitor with LFT. For carbamazepine, again you have to go for leukocytosis or leukopenia. And then how to add one more drug. Suppose if you have patient is having focal, you are not sure about the focal or generalized seizure, so you have started with valproic acids. So you have that normal protocol or normal dictum is you start with the low dose, not very high dose, like we go for around 25 milligram per kg of valproic acid. You can start with 500 milligram BD or twice daily, and then you observe for 3 months. Then if patient is having again one more seizures in between, you can increase the dose. You can go up to the maximum level of 2002 gram per day of valproic acids, and after 2 gram you are giving maximum dose of one antiepileptic drug. When patient is having again the recurrent or one more attack, then you go for one second drug. Second drug you can add, ideally you can go for the different mechanism of action, like you are using valproic acids, which normally increases the GABA activity or GABA neuron. Then you can choose one channel of it. It's like you can use phenytoin or carbamazepines along with valproic acids. When you use second drug, you continue with the first drug, valproic acids, you add on phenytoin as 100 mg TTS, then you go for the, again wait for 3 months more, then you go for maximum doses phenytoin. Gradually, if patients do not have seizures, then you gradually taper down the valproic acid. You don't stop the valproic acids. From 2 gram, you make it 1.5 gram, then 1 gram, then 500, then gradually you stop. And you can continue with the phenytoin level. So, when you are adding a second drug, you should not stop the first drug. That is number one principles. And that first drug, you continue for the maximum dose, maximum tolerable dose, you can continue. Then, once you add the second drugs, you gradually taper, wait for again 3 months to 6 months. If there is no recurrence of seizures, you can gradually taper the first drug and then continue with the second drug. And then dose of second drug is then further optimized based on the seizure response and the side effects. You can go for the, again for third drug. Sometimes in case of refractory epilepsy, you should go for 3 to 4 drugs simultaneously. When to discontinue? Again, this is very important and almost like $1 million questions. When to stop the antiepileptic medicines? So it's not that once you have started, you have to continue for lifelong therapies. You can give a trial for drug withdrawal. So when to give withdrawal therapy or drug withdrawal trial? One is if there is complete medical control of seizures for 1 to 5 years, like patient is having no seizure for last 2 to 3 years, you can think of giving trial of reducing the dose, not like to stop the drugs, but at least you can start reducing the dose. And then even there is one single seizures, like 1 year back she or he had one seizures and there was no recurrence. You can give a trial of after 1 year, sometimes 2 years. And if there is normal, definitely normal neurological examinations, including intelligence and normal electroencephalogram, or you can add here normal imaging. So if there is normal imaging, normal EEG, normal neurological examinations, and patient is a little bit of complete seizure free for last 2 years, then you can think of giving drug withdrawal trial, and gradually you have to reduce the dose. Like phenytoin patient, suppose patient is getting 300 milligram of phenytoin, you can reduce to 200 milligram, you can reduce to 100 milligram, then gradually you can stop. The status epilepticus, what is status epilepticus? It's a continuous seizures or repetitive discrete seizures with impaired consciousness in the interictal period. Like patient is having seizures and it continues. Like patient is having that abnormal movement, it continues. Now the question comes, like when you level it, after how many minutes you level it as status epilepticus. Patient is having seizures and it continues. Although theoretically it is defined as if seizure continues for more than 15 to 30 minutes, you should level it as status epilepticus. You cannot wait for 15 to 30 minutes to level it as 15 minutes. So practically if seizure lasts for more than 5 minutes, continuous seizures last for more than 5 minutes, practically we define this as status epilepticus. Again, there are two types of status epilepticus. One is called convulsive status epilepticus, where patient lost his consciousness, and one is patient may have some simple non-convulsive status epilepticus, where in case of especially absence seizures, patient with absence seizures may have also status epilepticus. It's known as absence or non-convulsive status epilepticus. Then durations, theoretically it should be more than 15 to 30 minutes, but for all practical purpose, if seizure lasts for more than 5 minutes, you level it as status epilepticus. Status epilepticus is a medical emergency. You have to treat immediately, because patients normally they do not die of seizures, but because they do die of cardiorespiratory dysfunctions, hyperthermia, metabolic disarrangement because of prolonged seizures. And most common cause of status epilepticus is the drug withdrawal or non-compliance, like someone prescribed antiepileptic therapy and someone suddenly stop and not taking medicine regularly, they may present with status epilepticus. Metabolic disturbance like hypo and hyperglycemia sometimes can have status epilepticus. Drug toxicity, some CNS infections like herpes simplex, Japanese encephalitis, CNS tumor, some refractory epilepsy can have status epilepticus. And in the first step in the management in patient with status of epilepticus is the cardiorespiratory care. This always you have to look for the cardiac status, respiratory status, establish on venous access, and immediately you have to start the treatment. This chart is very important how to go for status of epilepticus. Irrespective of cause of status of epilepticus, give lorazepam or diazepam. We give lorazepam because it is short acting, action lasts only for few minutes. So in adult, normally we give 2 mg to 4 mg over 1 to 2 minutes, and you can repeat that dose after 5 minutes. If patient improves with lorazepam, you can wait. And if you think that patient is having underlying seizure disorder or patient already on some medicines, then immediately after giving lorazepam, you have to bolus the patient either with phenytoin or with sodium valproate. If it is a new onset seizures, you don't know about the status of the patient, don't know any history, then start with phenytoin as the dose of 20 mg per kg at the rate of 50 mg per minute. If seizure recurs after bolus dose, you have to again half the bolus. You have to give, suppose patient is having around 50 kg of body weight, you can give 1000 mg of phenytoin. 1 ampoule of phenytoin contain 100 mg. You can dilute 10 ampoules of phenytoin with 100 ml of NS. You can give at a dose of 50 mg per minute. Wait for again 5 to 10 minutes, sometimes half an hour. If there is a recurrence of seizures, you can half the dose, like 5 ampoule. Again, you can give. If after giving second dose also, patient is having recurrent of seizures, you immediately transfer the patient to ICU. There you have to intubate the patients. You can sedate the patient with propofol or midazolam, and accordingly you have to give the treatment. Now, that second issue is if patient is already on valproate, then you can use injectable valproate instead of phenytoin. And second issue is if patient is elderly, because phenytoin is notorious to cause cardiac arrhythmia and hypotensions. In those conditions, you can consider valproate as a first-line drug instead of phenytoin. And sometimes after giving 2 doses of phenytoin, if seizure recurs, then you can consider sodium valproate, and sometimes phenobarbital you can consider. But phenobarbital is very difficult to get as intravenous, very difficult to get. So that in our practice, what we do normally in emergency, you give lorazepam 2 to 4 mg IV stat, and wait. If seizure recurs or if patient is having history of seizure, then you bolus with phenytoin, either with phenytoin or valproate. If patient is on phenytoin, you can give phenytoin. If patient is on valproate, you can give valproate, and either of this you can choose. And if patient is being elderly, better go for valproate. If you are suspecting chronic liver disease, choose for phenytoin. Whatever dose you are giving, phenytoin you have the bolus if patient is having recurrent of seizures. Otherwise, you can go for normal dose of 100 mg TDS. After giving half dose of bolus also, if patient is having recurrent of seizures, you have to admit the patient to ICU and give the IV anesthesia, or you have to sedate the patients after intubations and ventilations. So this is all about seizure. There are so many things I have not touched: the pathophysiology part, drug toxicity part, and different anti-epileptic drugs, new drugs, all drugs. That one you will go through your normal textbook, like either in the Davidson, or you can go through the Davidson, which is enough written in the Davidson. Otherwise, you can, for reference, you can go for the Harrison. Okay, thank you.
Yes, sir. Sure.